one of the early guys to do the gluteal flaps and the breast flaps. And then 20 years ago, I discovered avascular fat grafts. But you cannot reliably transfer so much tissue without blood supply. So I went back to the flap. But this time I'm talking to you about incision-free flaps. So why do we have to cut it and bring it up? Why can't we just suck it out, slide it up, and hold it up there, right? I mean, here's an example, and you could see in one procedure, now there's a suture there that we put in. When I pull the suture, I've recruited a breast. And here it is, we recruited 7 centimeters below the fold here, and in one procedure, we're able to create a breast there. Basically, if you just put the first ring, it's not moving here somehow. It doesn't pull up. Somehow the movie is not playing. But if you do the dissection, it moves up. So it's not enough to just put the suture that recruits. You have to release the fibers, and I'll show you that in a minute. So the concept here is that you can gain up to 10 centimeters of skin below the mammary fold. You can gain skin from the lateral side, and you define new mammary fold, and you gain about at least 200 cc's of tissue. It's basically 2 flaps. It's a Ryan flap and a thoracic flap. Obviously, I showed you how I harvest the fat. I'm not going to consider that. I like to have it very dilute, and then I like to re-inject it like I showed you here, but with going through multiple entry site and passing multiple passes, delivering with a 3 cc syringe and a 30, 25 centimeter passes, and I keep on passing multiple layers as I go through it. And basically, my most common operation is removing an implant, cosmetic implant, and replacing with fat. And you can see how we can basically give her the same volume she had. Pretty much, I can tell a patient, ma'am, if I remove your implant and I do this fat graft and the flap, you will have the same bra cup, the same volume you had without the implant. But the great application is for these difficult breasts. This is a tuberous breast. So we have it expanded. So you could see the expansion. It goes to passive fleece resistance, so the nipple gets larger. But I'm going to recruit all of this green line into the breast. And here it is. Now we put the suture, and you really don't get much when you put the suture. But once you do the dissection, that's when you really release the fibers that allow the advancement and create a wound healing interface. We're putting the suture, we really create a breast. And here she is before. This is, again, static pictures. And in one operation, we got to this. MRI shows before and after. One procedure, total autologous restoration of a tuberous breast. And this is the series, the baseline, the expansion, the fat grafting, the putting of the suture, and the final result. The beauty here is that on the table and 1 year later, it's the same. Why? It's a flap. Flap's not going to lose volume. So you really go back to the flaps here. Another example, before and after. Another example, oh, this is the constricted breast. She's lacking the lower pole. So we're going to basically give her a lower pole by recruiting this into her breast. Obviously, I have it expanded. You can see she's swollen there. And here, one procedure, we restore the lower pole. This is a patient that actually, she came to me from Europe. She heard about our procedure. She didn't want to have implants. She did not want to have a lift. She has kind of a constricted breast deformity. I'm going to recruit all of this and fill up with fat. She's very skinny. But again, my best patients are skinny because their fat is really all, pleuroplasm. I inserted the suture. I put the fat, pull the suture up. There's a double bubble. Then with the distraction, we're going to loosen up, lose the old fold, and create a new fold. Before and after. Now, the skinny patients, again, these are the most challenging because an implant will all look fake and there's not enough fat. So we expand her, we plan the procedure. We're going to take fat from basically everywhere. And you can see how once we put the fat, I pulled the suture and I got this breast that comes out by just pulling the suture. It's a flap. It's 2 flaps at the same time. One operation. We go from here to there. The donor side is a plus because we improve her contour, narrow her waist, give her a bigger butt. 1 year post-op. Again, baseline, expansion, recruitment, fat grafting, pulling the suture. On the table and 1 year follow-up, it's the same. It's a flap. It's a flap's not going to lose volume. I'm proving it's a flap. The pigmented lesion became part of the breast. Another tuberous breast. The pigmented lesion became part of the breast. Here's a lady, I removed her implant, and you can see how her tattoo was distorted. The skull was distorted being part of the breast. So I recruit lateral thoracic, and I recruit lower abdominal. And again, we always give a buttock augmentation with our procedure without touching the buttock. Another one with a tattoo here again. Baseline, expansion. This is the new Eve, by the way, that has no adhesive. It's really much more comfortable on the patients. And here she is expanded. We're going to recruit this into her breast. And one procedure, notice how the tattoo became part of her breast also. It became closer to her breast, so it was recruited tissue, and we improve her donor side. Again, this is a good way to recruit. This is a very thick, tough tissue, African skin, but patients have that lateral fold in the breast they hate, and I recruit it and bring it part of the breast with this procedure. This is, again, the skinniest patients. I mean, this is a challenge to do any augmentation on a patient like that. She has no fat. We expand her, we recruit that tissue. That shaded area, the loose shaded area, is what we're going to recruit into the breast. And you can see once I pull the suture, we got a breast. One procedure, before and after MRI, 1 year later. You okay?
No.
Something fell off? All right, continue. Before and after, again, same thing, same thing. Again, what you see 5 days post-op is what you see 1 year post-op. It's a stable, it's a flap. I can show you case after case. Before pulling the suture, the results on the skinniest patients, before and after MRI. Try to get MRI on all my patients with the donor site. I've done basically over 500 of these. Oh, by the way, this is an important step. I put all my patients get that splint post-op for a few weeks. That preserves also the swelling. 4 days post-op, 1 year post-op, no change. Expanded. You see, by putting the suture, you create a breast. By putting the suture, you create a breast. Putting the suture creates a breast. Now, sometimes they bruise more than others. It's very important. Those needle sticks are very important. With time, we learn how to get it better at taking care of those needle sticks. Baseline expansion, fat before and after on the skinniest patients. And you can see how the tattoo also became part of the breast. So, it's a very powerful tool. I use it for breast augmentation, obviously. I use it also for the congenital breast. The suture, pull the suture is not enough. This is an implant removal. You see the scar of the previous implant. You see that scar of the previous implant. And then when you go in there, you have those cutting instruments. Very important. Percutaneous dissection with long cutting instrument that I had to develop because not available. 18 gauge is not good enough. This is a cutting instrument, very thickness, very length. And you go there, while the assistant is pulling, you undermine, inset the flap. It's very important to undermine, create, so that, and as you do it, once you do that, then you get around breast, because now you created a space for the breast to sit on. Now, the tool for this, again, I had to develop the tools for this. Initially, I used to sharpen my own needle, but this is a double-pointed needle that's long enough that allows me to go all the way through that pair. And it's got a saber-like cut so that it stays as a rudder in the same subdermal plane as I passed along the mammary folds. So we start right at the clavicle, go there, pass it through, and complete the loop. Basically, you put the loop in, and then you have to divide the fibers that prevent advance of the abdominal wall. Once you do that, you have to go and inset and allow those fibers so you really create that fold there. And I'll show you here. So here I'm passing the suture all the way. You have to go all the way deep over the turbis, then along the mammary fold. This I've removed an implant, so this is how the incision to remove the implant. Complete the loop, and once you complete the loop, you create a fold there. Then you have to release it. very important, to release it and undermine it so that you complete the fold. Passing the suture, you go straight from below the clavicle, aim at the angle of Lewis, then stay deep, deep over the periosteum of the sternum. And that's a good way to correct iatrogenic symastia. And then you grab the dermis, you stay along the dermis until you go to the other side there and complete the loop. I use it for breast reconstruction. This is a radiate. This actually happened to be a sad story. This is a medical student. This young girl was a medical student with us, and she had breast cancer and was heavily irradiated. So we grafted her a few times to reverse the radiation damage, and then we expand her, and then we use the Eve to expand her. You can see the expansion. Then we go recruit tissue there, and then really it took us, I think, 6 sessions to get her. But here's one of the sessions with the prophylactic on the other side. And that's what gives me the breast there. So that's what completes what Dr. Bashik was showing there. If you do this procedure, instead of do 7 or 8, you probably get rid with 3 or 4 or 5. This is after one of the raft, and then additional final result. I think this is the final result there. We did a prophylactic mastectomy on the other side. We improved her body contour all along the way. She has a nice waistline, and the other breast was removed prophylactically. This lady is actually a physician that came to us. She had cancer on the left breast and had a previous mastectomy on the right, which was also radiated. So then we expand the mastectomy, and we're going to do an immediate reconstruction on the other side. And you could see how, with the immediate reconstruction on the table, we had to give her some fullness by grafting the pectoralis. And then we pull the suture and create a breast on the other side. And here she is after one procedure. And then we came back, expanded her, and here she is before the second, that's the only post-mastectomy procedure. And here she is, and after touch-up, final result, before and after. This is the alternative to the tram, to the JAP, to the free flap. Again, this lady is a physician. She's a lady in. So this is the implant removal is really a big procedure. This lady has implants, and we basically, once we remove the implant, she's completely flat. But once you pull the suture, you restore a breast. Before and after, you see her MRI, she had basically, essentially nothing, just a shell of tissue. And then post MRI, we gave her a breast on a skinniest patient because mostly it's a flap recruitment. Now, it's a good way to correct all kinds of breast deformities. This lady had dropped her inframammary fold, so you bring up where you want to be. You have abnormality, symastia. This lady had one breast looking this way, the other one that way. She already had 4 implant replacements, and she's completely distraught. So depending on how you design these sutures, you can fix it. This is one patient here, sorry. So, okay, sorry. So depending how you design those sutures, you can recruit more on one side to bring it immediately, recruit less. Her left breast crossed the midline, so we corrected that by bringing the suture there and recreating the normal fold. And here she's on the table, remove the implants, and then put the right suture, and before and after, 6 months post-op. So it's a good way to correct abnormality and to restore the normal fold in the implant cripples. This is a mastectomy patient. She had bilateral prophylactic mastectomies. She did like her implants. One operation, we removed the implants, put some fat, and restored it. 2 years follow-up, no implants. Very common procedure. Comes to me, she has cold breasts, she doesn't like them. One first operation, we half the size of the implant, double the thickness of her tissue. And now she's at 250, and from 550 to 250. Then the 250 becomes 130, and then the 130 becomes no implants. So we go from 550 to no implants. Again, typically if they're not radiated, I tell the lady 2, maximum 4 procedure. I can take you from your implant reconstruction to totally autologous, no implant. Same size, all natural breast. You restore sensation, restore the weight. Again, same situation here. Ridiculous looking breast because of implants there. And in 3 procedures, we improve her buttocks and give her more natural looking breasts. Same thing here. 3 procedure, remove her buttocks, and give her natural looking breast. Now, I take care of those disasters where she is radiated, failed implants, very skinny, and again, it takes me 7 procedures to get there, but you still can give her, even the skinniest patient get that. Again, all those patients who have lost their implants, very, very common because they get 1 step to implant with disasters, and then we can restore it by doing these. This is a lady with radiation. This is a 15 years follow-up. She had radiated mastectomy. We did immediate on the other side, and this is a 15-year follow-up on her. And another one, radiated mastectomy, failed implants. She's also a physician. Failed 1 step to implants. Again, came to me crying, very skinny. This is 3 sessions, 5 years follow-up. So it's really a nice way to recruit tissue below the breast, into the breast, create new mammary fold, create a roof fold, collapse the implant cavity, and restore it. You can do serial advancement. You see, this is a radiated, you're looking at as a silicone implant shining there and across to you on this radiated tissue. And you could see how, from her shape of her belly button, from 1 to 3, how we really brought that belly button up. She's implant free here, and this is a 5-year follow-up. She gained weight again, but she is now totally autologous. So, well, I've had some complications. Premature suture break. The suture is the number 2 PDS. And so it loses tensile strength at about 6 weeks. So you got to make sure you create a healing interface. And it's very important not to tie the knot on the tension. You have to really completely undermine, completely release the tension with the dissection so that the flap sits there without tension. You can get some necrosis, especially in patients that have had multiple previous surgery. And sometimes if you don't completely release the old fold, you can get double bubble. An important thing here, I tell the patient it's going to be uncomfortable for a while because you have traction on the nerve and that causes some pain. I tell them you're going to be uncomfortable for a while. You can't raise your arm too much until things accommodate. This is where I've had something, it's a flap, so you can get necrosis. It's a flap, and especially on the lady who had previous abdominoplasty and incision on their breast and breast reduction incisions. Now this is a case, happened to be the sister of a physician for breast reconstruction. Then we lost again some minor flap because she had tummy tuck, incisions on the breast all over, and you get some tissue loss. This is another complication. This again is a young doctor. She came to me for breast augmentation, and we expanded her. We put it. She looked great 3 days post-op. She came back 6 weeks later. It broke down. So I have 2 types of suture. Same needle. You can have it in PDS or you can have it in Prolene. So my radiated patient now, I always put Prolene because radiated patients take a long time to heal. I don't care. I put Prolene. If it bothers them, a year later I can snip it out. But the cosmetic, they don't like to have, sometimes they feel the suture. So we had to go back and fix it again to take care of this before and after 1 year follow-up. So in conclusion, the incision-free flap is really a reverse abdominoplasty and fat transfer. I call it RAFT because I developed it to salvage initially the implant failures. You really transfer to the breast a significant amount of tissue, no new scar, donor side is a plus. You create new breast fold, you can correct symphysis and other implant deformities. The drawback, of course, is that it takes longer to do. It's an operation. It takes a while. Doing this takes a while. It takes a few weeks to return normal activity. It's a reverse tummy tuck, so they're going to be tight on their shoulders because you've suspended the abdomen on the shoulders there. But it's a very powerful tool to breast reconstruction. The tools there, Polytech actually distributes there in Europe. This double-pointed needle, the K needle, the lipografter, and the Eve expansion. So again, you're all welcome to come and see this in Miami anytime. And if you want me, I'll come over and operate at your place and show you how we do this. It's a great operation. Thank you for your attention.